Hello and welcome back everyone. So continuing our review on the pediatric medicine, in this video we will talk about the epiglottitis. Now epiglottitis, which is also known as supraglottitis, is an acute inflammation of the epiglottis, and it is a medical emergency because there is a risk of sudden airway obstruction and death. And the epiglottis is a piece of tissue located at the base of the tongue, and it prevents food from entering the trachea. So as you can see in this picture here, we have the epiglottis located here at the base of the tongue, and here we have the trachea. And in epiglottitis, the epiglottis become inflamed, it become larger in size, edematous, and it might block the trachea here, and it might lead to airway obstruction. So it is a medical emergency. And in the second picture here, we have an endoscopic picture showing an inflamed epiglottis. Now epiglottitis is rare nowadays because it is mainly caused by Haemophilus influenza type B, and vaccination, which is the Haemophilus influenza type B vaccine, has decreased its occurrence. So the Hib vaccine is given early in life, and it prevents epiglottitis from occurring. Now it is mostly caused by Streptococcus and Staphylococcus species, and that occur in immunized children. And immunized means immunized against Haemophilus influenza. Now Candida may be a cause in immunocompromised patients. Now let's talk about the clinical features. So epiglottitis is characterized by an acute, rapidly progressive course of high fever, sore throat, dyspnea, and respiratory distress. And the degree of respiratory distress at presentation is variable, and lack of respiratory distress at presentation is deceiving, and it may lead to misdiagnosis, which can be dangerous because this patient might rapidly progress into airway obstruction and death. Now respiratory distress also could be the first manifestation of this disease. Now the classic presentation of epiglottitis is usually a healthy child suddenly develops sore throat, fever, and within hours the child appears toxic. Swallowing is difficult, breathing is labored, and drooling is present. And the child may sit in tripod position, sitting upright and leaning forward with the chin up and mouth open while bracing on the arms. So as you can see in this picture here, the child is sitting in a tripod position, and they have high fever and bluish lips, and they have drooling. So saliva is drooling because this patient can't swallow their saliva because they are tachypneic, they are breathing fast, they don't have time to arrest breathing and swallow saliva, so they have drooling present, and they may have stridor with breathing in, and they also have muffled voice, and they have retractions, so those are intercostal and subcostal retractions. Now a brief period of air hunger and irritability is followed by a rapidly increasing cyanosis and coma and respiratory arrest and death. And stridor is a late finding and suggests near complete airway obstruction. When you hear stridor, this means that the airway is more than 90% obstructed, and this is very dangerous. And the barking cough, which is typical of croup, is rare in epiglottitis. Barking cough highly suggests croup and doesn't suggest epiglottitis. And usually, no other family members are ill with acute respiratory symptoms with the epiglottitis child. Now let's talk about the diagnosis. So diagnosis is clinical in patients presenting with the classic presentation, and if the diagnosis is uncertain, then lateral neck films should be taken at the bedside in extension and during inspiration with minimum disturbance to prevent airway compromise. And thumb sign might be seen in the radiograph. So as you can see in this picture here, we have the trachea here, and here we have the epiglottis. It is inflamed and big, and it is blocking the airway. And if the thumb sign is not seen, then diagnosis require visualization using laryngoscope in the operating room or in the intensive care unit. That is because visualization is an anxiety-provoking procedure, and it might lead to airway compromise. And if you are in the operating room or the intensive care unit, you have access to intubation tools and ventilators which are required to keep the patient alive. Now, in visualization, the epiglottis is large, cherry red, and swollen, and anxiety-provoking interventions such as phlebotomy, IV placement, placing a child supine, or direct inspection of the oral cavity should be avoided until the airway is secure, because they may lead to airway compromise. And if the patient requires to be transported, a physician skilled in airway management and intubation should accompany the child at all times. Now, blood cultures should be withdrawn, and they are positive in up to 90% of patients, while cultures from the epiglottis are less sensitive. Now let's talk about the treatment. So first, you establish a definitive airway using either endotracheal, nasotracheal intubation, or if failed, then tracheostomy is indicated regardless of the degree of apparent respiratory distress, after confirming the diagnosis, of course. And that is because around 6% of children with epiglottitis without a definitive airway die, compared to less than 1% of those with a definitive airway. And the duration of intubation depends on the clinical course of the patient and the duration of the epiglottic swelling, and extubation is done when swelling subsides, and examination is done using direct laryngoscope or flexible fiber-optic laryngoscope. Now, intubation usually lasts for 2 to 3 days because response to antibiotics is rapid. Now, during preparation for intubation, by gathering the right personnel and equipment, you keep the patient seated and upright, and you provide oxygen and administer nebulized racemic or L-epinephrine. And in the event of total airway loss, you attempt vac valve mask ventilation, and steroids are used to decrease mucosal edema of the epiglottis, and you use methylprednisolone 2 mg per kilogram intravenous or dexamethasone 0.15 to 0.6 mg per kilogram, and you administer antibiotics, cefuroxime 50 mg per kilogram per dose, or cefotaxime 50 mg per kilogram per dose, or ceftriaxone for the same dose. And those are used empirically. And in regions with increased cephalosporin resistance, vancomycin, which is 10 mg per kilogram per dose, intravenous, should be added. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support more, please consider joining the channel by hitting the join button near the subscribe button down, or by using the link in the description of this video. Thank you for watching and peace.